Okay, it's 12 o'clock. Good afternoon, everyone, and welcome to this webinar hosted by the MRC's Hubs for Trials Methodology Research Trial Conduct Working Group. I'm Chris Rogers from the Clinical Trials and Evaluation Unit at the University of Bristol, and it's my pleasure to introduce Jodi Taylor, our speaker today. Jodi is a research associate based here at the Clinical Trials Unit in Bristol. Jodi is a trial manager with extensive experience of running randomised trials, particularly in the cardiac arena. In this webinar, Jodi will be telling us about how she has overcome some of the challenges of setting up and running a large and complex pre-hospital trial in patients experiencing an out-of-hospital cardiac arrest, the Airways 2 study. Jodi's presentation will last around 20 minutes, following which there will be an opportunity for you to ask any questions or make comments. In case you're not familiar with how to do this, in WebEx we'll be showing you a slide later on to provide some guidance. So now, without any further ado, I'll hand you over to Jodi for her presentation.
Thanks, Chris, and thank you to everyone for joining us today. So as Chris said, I'm going to be talking about some of the challenges faced setting up and running the Airways 2 trial. I'm going to be focusing on elements of the trial setup that have been a particular challenge to us here at the CTU. I won't be talking about challenges associated with carrying out research in patients that lack capacity. So the trial is funded by the NHIR, and we aim to complete the trial by April 2018. Airways 2 is a cluster randomised trial of the iGel versus trachea intubation in out-of-hospital cardiac arrest patients. And we're interested in the effectiveness of the first advanced airway management technique paramedics use when attending an out-of-hospital cardiac arrest patient. So in this trial, we're comparing the clinical effectiveness of trachea intubation against the iGel. Trachea intubation is a skilled technique that requires the use of a laryngoscope to see the patient's larynx. The paramedic then needs to place a cusped tube at the correct level in the trachea. And we're comparing it to the iGel, which is a second-generation surrogatic airway device, and this is much simpler to insert. The iGel device is simply inserted in the correct orientation into the patient's mouth, where it sits just above the voice box. Now, both interventions are already used as part of standard practice across all of the ambulance services, but there is real equipoise between the two techniques. So in order to save as many lives as possible, we need to find out which airway device should be used first when treating a cardiac arrest patient. In this trial, we're using the modified ranking score measured at hospital discharge as our primary outcome to help determine which intervention is the most effective. The modified ranking score incorporates survival to discharge and is widely used in out-of-hospital cardiac research. The modified ranking score is usually presented on a scale of 0 to 6, with death being 6. Now, when I started working on this project, it was a real surprise for me to learn that the current rate of survival in out-of-hospital cardiac arrest patients in the UK is only 9%. So a 2% improvement in the proportion of patients achieving a good neurological outcome would be clinically significant. Now, to demonstrate this improvement at a 5% level of significance, we need to enroll over 9,000 patients, and our aim is to do this in just a 2-year recruitment period. The trial is a cluster randomised trial where randomisation is carried out at the level of the paramedic rather than the patient. Now, based on our feasibility work, we predicted that in order to achieve our patient enrolment rates, we'd need to recruit over 1,300 paramedics. This slide shows the pathway for an out-of-hospital cardiac arrest patient. Patients that have an out-of-hospital cardiac arrest are usually attended by an ambulance crew, and then if the patient survives, they're admitted to ED, treated in ICU, and recover on a ward before being discharged home. So in order to enrol 10,000 patients, we think we'll have to screen over 100,000 cardiac arrests. To be enrolled in the study, the patient must be attended by an Airways 2 paramedic, and resuscitation must be attempted. Out of our 10,000 patients, we expect only 4,000 to survive into hospital, and only 1,000 of these to survive to hospital discharge. Now, this trial can only be successful if there's really good collaboration between the ambulance services and the acute hospitals. 4 different ambulance services have agreed to take part in the trial. So we've got South Western, who's also acting as the sponsor, Yorkshire Ambulance Service, East Midlands and East of England. And these ambulance services are pretty representative of all the ambulance services across England. Using reported cardiac arrest data from these 4 ambulance trusts, we identified all of the acute trusts which have in the previous year received a cardiac arrest patient, and we identified 95 different hospitals. Ethics approval was received in September 2014, that should be, and we plan to start patient recruitment in the following June. Now, this gave us an 8-month window in which to recruit and train all our study paramedics and to obtain the support and approval from all of these 95 acute trusts. I think at this point I thought, oh my gosh, what have I let myself in for? Now, my first focus was to ensure that we obtained approvals from the ambulance trust as soon as possible so that they could start recruiting paramedics. And there was quite a lot of work to do here around working out what was feasible in each ambulance trust. We needed to employ research staff, we needed to standardise equipment and protocols that the study paramedics could follow. So we held 2 joint ambulance trust meetings before we thought about asking the ambulance trust to complete their SSI forms. We identified all the key stakeholders and made sure they could attend the meetings. Now, these meetings were really successful because we invited people that could actually make decisions and implement changes in each of the ambulance services. At the first meeting in November, we outlined the trial, and then we held workshops with the ambulance trust to identify problems. And then at the second meeting, we actually asked the ambulance trust to present their solutions to any of the previously identified problems. In parallel to the sorting out the ambulance trust approvals, I started looking at the acute trust approvals. Now, everyone knows obtaining approvals can be time-consuming and expensive, but for this trial to be successful, we had to get approval from all 95 hospitals. We couldn't really go through the usual route of selecting research experience sites that had resources to support the study, as we really needed every single one to take part. So we needed to make the approvals process as simple as possible and think about different strategies we could employ. So first of all, we identified all the key stakeholders. We made sure there were very clear lines of communication, and we wanted to make sure there was a very clear message about why the trial was important and how it could not succeed without the support of every hospital. We contacted the lead CRN and asked for the help with setting up the study, and they identified 4 main networks that would be involved and 8 others that may have hospitals in their patch that could receive Airways 2 patients. The lead CRN agreed to give 30 minutes service support costs for each patient approached, and this message was made clear to the other networks involved. The CRN also agreed to provide some administrative support for the ambulance trust. Next, we invited all the critical care leads from the relevant CRNs to a teleconference to discuss the study. We asked the critical care leads to promote the study to the acute trusts in their patch and asked them to help us identify local collaborators within each hospital. We also took their advice on where and how we should employ our regional research nurses. I knew if we were to stand any chance of getting all the approvals from the acutes by March 2015, we'd need to streamline the approval process. So we worked very closely with the lead CRN, and instead of using a generic SSI for each site, they gave us a normal SSI for each site. They gave us permission to use the generic SSI. They also agreed that as the intervention was carried out pre-hospital and patients were being enrolled by the ambulance services, there was no need for the acute trust to localise patient documents, but that instead we could use ambulance-headed or sponsor-headed paper, and that the study team could supply the acute trust with these documents. We also decided to use a local collaborator rather than a PI, and this meant trusts could use research nurses as the main point of contact rather than a clinician or a doctor. And finally, to streamline the process even further, we used a one-page agreement instead of a third-party contract, and this didn't require any sign-off. Communication with the acute trust started 3 months prior to the submission of the generic SSI. We first contacted the R&D departments and notified them that they would be invited to take part in this important study. We then started working with the acute trust to identify suitable local collaborators. Some hospitals were slightly uneasy about research nurses acting as the point of contact, and we also had to do quite a lot of the work with the acute trust to explain why we did not want them to localise patient documents. We offered the acute trust 30-minute service support costs for each patient they approached and a £40 payment for every complete data set they submitted. We also worked out an NIHR accrual model where accruals were split between the ambulance services and the acute trusts. We promised that there would be minimal work involved in the site setup and that the amount of data we would ask them to collect would be kept to a minimum. We also promised a regional research nurse as a main point of contact and someone they could utilise to help with consent and data collection if necessary. So, at the point we planned to start patient recruitment in June 2015, we had 72 out of our 95 trust approvals in place. One of the things I found really interesting was that in the regions where the CRNs were very supportive of the study, the approvals were processed very quickly and we had minimal work to do with the sites. Whereas in the CRNs who were more pessimistic, we had to have lots of contact with the sites ourselves and the approvals took longer. Now, with this being a very large study with lots of different people involved, the CTU really had to think carefully about how we were going to manage the study and who was responsible for what. We needed to ensure mechanisms were in place to ensure good communication between the ambulance trusts and the acute trusts. The ambulance trust needed to deliver the intervention, let the study team know they enrolled a patient, provide us with the patient details, let us know the survival status of the patient, and tell us which hospital the patient had been taken to. They also had to report data on the airway management they delivered and report any SAEs. The acute trust needed to be able to identify any airways 2 patients that entered their hospital. They needed to monitor patient survival status. They needed to approach and consent the patient at the right time, and depending on which consent option the patient chose, collect a set of data. And they also had to carry out SAE reporting. So we needed a communication system that would allow 1,300 paramedics to tell us if they had enrolled one of our 10,000 patients. So we employed a research paramedic in each ambulance trust to manage the paramedics in their region. We set up a hotline in each area, and the study paramedics were asked to ring and leave a minimal data set about any patients they enrolled. This information was then entered as close to real time as possible into the patient database. If the patient survived to hospital, the database would then automatically notify all registered users at the acute trust when a new airways patient was brought in. So we also employed 4 regional research nurses to oversee the acute trusts. As we wanted to maintain blinding in the study, the CTU acted as an intermediary between the research nurses and the paramedics. So to make this process really efficient, we needed a good trial management system that could handle everything apart from the initial notification from the study paramedics. We anticipated that the TMS would have over 100 users, which would include research paramedics, principal investigators, regional research nurses, ward staff, as well as the study team. We wanted the TMS to provide a mechanism for online training, act as the primary method for communication, include a document repository, aid the CTU with trial monitoring, include a patient database, and if possible, reduce the carbon footprint of the trial. So I'm now going to focus on site setup and show you a few features of the trial management system. I'll be looking at focusing on how it looked for acute trusts, but similar systems were in place for the ambulance services. Due to the large number of acute trusts, we decided not to carry out any face-to-face initiation visits. Instead, we produced a very detailed manual They explained all aspects of the trial, including how to register as a user for the trial management system. The manual was sent by email to the local collaborator, and we asked them to distribute it to anyone at their site that would be working on Airways 2. We did do a telephone follow-up with the site, and this was done by the regional research nurses with the local collaborator. It was a good way of opening up lines of communication with each trust, and it gave them an opportunity to highlight any problems they thought they might have with the study, and it let us check that the local collaborator was happy with their responsibilities. So all users were asked to go to the trial website and register for an account. They were asked to provide all their local contact details, which makes the database create a very useful automated contact book. On registering, users were asked to complete their delegation log entry. They were asked to upload their CV and GCP certificates, and once this was complete, the user was able to access their user homepage that you can see here. Training for individuals consisted of reading the manual and watching 5 online videos, which lasted about 30 minutes. The videos for the acute trusts explain the background to the study, the rationale for the study, and demonstrations of each intervention being used. The individuals were then asked to complete a personal training log, which they then had to upload to their electronic site file. Now, one of the neat features of the TMS was that it created an online delegation log for each site, and whenever a new user registered for an account, the local collaborator was notified by email. The local collaborator then had to go into the TMS and check the delegation log entry for the user was correct and that they'd uploaded the relevant supporting documents. The local collaborator could then electronically sign off that user's account. And once this was done, they were able to access the patient database. Now, I think one of my favourite features of the TMS was the electronic site file. Now, this site file was split into 2 different areas, the trial master file and the local site file. The trial master file is maintained centrally by the CTU, and we upload all essential trial documents, so all the regulatory approvals, amendments, any study documents or protocols. Now, the electronic site file pretty much replicates the paper site file. So here, if you click into the study-specific folder, you can see various sub-tabs. So the patient documents, consultee documents, and the protocol. And then if you click into the protocol, you can see all the different versions of the protocol uploaded. You can see the version number and which one is the current version. Now, the database is really clever in that there's various workflows built into it. So when you upload a new document to the trial master file, it asks you which user groups you would like to notify about the new document. Now, all sites have read-only access to the trial master file, so there's no need for sites to add these documents to their local site files. Within the TMS, each site has their own electronic site file, and here they upload any local documents. So any training records are in correspondence relevant to their site, local R&D approval letters and amendment letters, and sites are expected to maintain the local site file themselves. Now, this system is fantastic for us at the CTU, as all the study documents, both central ones and local ones, are all held in one place. And we can monitor local site files for every site without ever having to leave the office. So just briefly, I'm going to talk about the patient database. All of our CTU databases operate on a similar system. Each patient is shown on one row, and we have the CRF groups along the top, and we have a traffic light system where green shows completed forms and red shows CRFs that haven't yet been started. And you just click onto one of the icons to access the CRF. In Airways 2, different users can access different forms. So the research paramedics can access forms A to F, and the acute staff can access forms G to I. Forms only become available when required. So in Airways 2, Form D is only completed by a research paramedic if the patient survives to hospital. They then enter the patient details and they choose the hospital the patient has been taken to. Now when they hit the save, the database automatically notifies all the users registered at that hospital that have the new patient. And so the database really acts as almost a live patient tracking system. So once the acute staff receive an email, they can access the database and see a list of patients who are currently in their hospital. They get presented with the patient details entered by the study paramedics and asked to confirm if they're correct. The database also has a lot of other neat features which makes life easier for the acute trusts. So once they identify one of the patients, the database creates personalised consent packs containing invitation letters, PLs and consent forms. The sites can then download these and print them off. If the patient consents, sites are asked to upload the completed consent forms and say whether the patient is consented to active or passive follow-up. The database produces personalised GP letters for sites to download, and it only activates forms that are relevant to the patient's survival status and consent status. Sites also have to upload any SAE forms, and if this happens, the database sends an email to the CTU, so we know that there's been an SAE. So the system's really interactive, and we've had lots of good feedback from the sites. Now, I think our approach to setting up airways has been slightly different to usual, but all 95 trusts ended up giving approval. We now have over 250 registered users, and I'm quite surprised, but everybody has really embraced the electronic trial management system, and the sponsors really like it because they can monitor everything really easily. As for reducing the carbon footprint, I haven't yet had to send more than a handful of pieces of paper in the entire trial, and sites even download a template to produce prepaid envelopes for patients. So just to finish off, we're currently entering our 7th month of recruitment, and we have over 1,300 paramedics taking place, and we've enrolled over 1,700 patients. This now makes Airways 2 the largest pre-hospital airway management trial ever to be carried out. A couple of take-home messages. Ambulance services are becoming more research active, and good quality pre-hospital trials are possible, but you do need really good lines of communication and a willingness from everyone to think slightly differently about how trials are run. If you want more information about the trial, you can visit our website, or you can follow us on Twitter. Now finally, if you think of any questions later and you want to ask me, my email address is here at the bottom of the page. I think I'm going to hand you back to Chris now, who will screen for any questions.
Okay, thank you, Jodi, for that very informative presentation. As Jodi said, now it's time for questions. So if you have a functional microphone or a telephone connection and you wish to speak directly to Jodi, then please follow the instructions to raise your hand. Alternatively, you can type your question in the Q&A panel and then I'll read it out on your behalf. Okay, and you can see on your screen now some instructions on how to do that. Okay, so while we wait to receive any further questions, Jodi, perhaps I could just kick off by asking, first of all, did any of the sites actually insist on using localized patient documents? I know that was something you were trying to avoid, but did you have to do that for any of the sites?
No, we did have, I think there was 4 or 5 that really couldn't understand why they couldn't put it on their local headed paper, and it did take quite a lot of work from both the CRNs and the sponsors to explain that the intervention was carried out pre-hospital, and it was actually the ambulance trust that enrolled the patients. But in the end, all the sites have actually gone with that option of using our headed paper.
Okay, excellent. Right, I think we have a couple of questions. So I shall read out the first one and then we'll move on. We've got 3 so far. So the first one says, thank you, Jodi, that was a very interesting talk. Can I ask a bit more about the electronic trial management system? What is the name of the system? Who provides it? And did it take a long time to set it up?
Now, the electronic trial management system has actually been developed here within the CTU. We have some IT database managers, and they actually developed it bespoke according to my requirements. It has taken quite a lot of work to get it to this stage, and we are still doing some further work on it, but we hope to use it for some of our other trials as well.
Okay, and two people who have raised their hands. First, we have Robin Lerner from the University of Central Lancashire.
Hello, can you hear me?
Yes.
Great. Hi, Jodi. Thanks. That was really interesting. We're setting up something relatively similar, but in stroke, where we're doing a change in practice and a cluster trial. We're setting all our sites up to start kind of incrementally. I think you mentioned that lots of them had approvals, 90 or something, on the same day, or in place at the start of the trial. Did you start everybody at the same time? Of those slower ones, did they start incrementally? Would you recommend doing them all at the same time?
The acute trusts had to really have their approvals in place by the June, because it was actually the ambulance services that would start enrolling patients. I think if you can manage to do a stepwise process, it's obviously easier. The first couple of months of the trial was really manic for us with having all the sites starting at the same time.
Yeah, I bet. Yeah, thank you.
Okay, and we have a further question from Eleanor Mitchell from the University of Nottingham.
Hi, thank you very much for a really interesting presentation. I was actually going to ask about the trial management system, similar questions to what had been asked before. In terms of, which have mainly been answered, in terms of cost, was that just something that was kind of pulled in through your team?
Yes, so the study does support an IT manager sort of 50% of the time during the startup period, so we haven't actually costed how much.
Okay. How long, you may have said this before, how long did it take to build?
Yeah, that's quite difficult to answer again. So I started talking to them about it in the October, ready for the system to be ready by sort of March. They didn't work on it full time in that period though.
Okay. Okay, fair enough. I've actually got a colleague with me, Sarah Fay, who's got a question. So if you don't mind, she'll ask you something.
I was intrigued by your mention of Twitter. I'm wondering how you found that, and whether it's been focused on the paramedics, the patients, or both.
Yeah, so we actually resisted having a Twitter account until fairly recently, but the focus is really from a paramedic point of view. They seem to be really engaged in Twitter, and there's lots of discussions about the study design and things. I guess one thing I would say is if you're going to use Twitter to promote a study, you do have to be prepared to monitor it and answer any questions.
So is it time-consuming?
It can be, but it's usually after sort of, say, Airways is presented at a conference, there's usually quite an active period, say a couple of hours following a presentation.
I see, thank you.
Thank you.
Okay, do we have any further questions from anybody? Oh, yes, has another one come in? I think, have we got a second question? No.
Oh, hello.
Sorry. Yes, Robin?
Hi. So I was just wondering, again, with your electronic system, did you look at any of the ones that are available already? Because there are systems like, Microsoft SharePoint that can do documents, and there are systems like RedCap, which is an online kind of custom data management tool that are either free or relatively free. Did you look at those before you got?
So our IT team have looked at quite a lot of different systems, and I think weighing up all the different advantages and disadvantages, we feel as a unit at the moment, writing bespoke systems is much more beneficial. We have a lot more control over what you can do, and some of the ones that do give you more control cost an awful lot of money.
Yeah. Okay. And my other question was, did you ever look at the cost, how much money you saved in printing? Just because we think now, after we started up, we probably could have bought all the sites in an iPad, and they could have done it electronically for the same amount we spent.
Yeah, I mean, it is a real cost. I mean, having to sort of print out 100 site files and then having to maintain that for a 3-year period, and the postage involved in it. This electronic system has saved us quite a lot of money on printing.
Okay. Thank you.
Okay, just one final question from me, if I may, Jodi, and then we'll wrap up. What sort of patient consent rates are you achieving within the study?
Yeah, we're quite pleased with that at the moment. I think it's sitting at about 75% at the moment, and for a retrospective study, I think that really is very good, especially considering lots of patients don't regain capacity, and we're having to look for consortees to consent for them.
Okay, thank you. Well, if we don't have any more questions for today, then I think we'll leave it there. And as Jodi has said, if anyone wishes to contact her directly afterwards, then she's given her email on the slides, and I think you're happy for people to follow up with you directly, Jodi, is that right?
Yeah, that's fine, yeah.
Okay, so just a final couple of points before we wrap up. Firstly, we have been recording today's webinar, including the Q&A session, and we'll be emailing you a link to this within the next week or so, maybe slightly after Christmas, given the time of year. And you can use this link to listen again or to share it with anyone else that you think might be interested. Also, it should then be possible for anyone to access the recording of the webinar as the previous webinars via the Trial Hub Network website. Okay, so that will be available in due course. I'm in the process of also finalising the webinar for January, so invitations for that, including a link to pre-register, will be distributed through the usual channels, so please look out for that. And so finally, it just reminds me to say thank you to all for joining us today, and especially to Jodi for her very clear and informative presentation and for fielding your questions. And I hope everyone has a lovely Christmas break and all the very best for 2016, and I hope you'll be able to join us again next time. Goodbye.